Morning, everyone, and welcome to our PDAB webinar this morning. We are really excited to preview the battleground that's going to open up in PDAB on a number of fronts. And we're really pleased to have this expert panel with us. It feels like we've been in the trenches for quite some time on this issue. There's a lot of expertise that's growing not only within our panelists and their organizations, but also within the patient community. And so we wanted to use this meeting as an opportunity to look back at some of the challenges that we've had in 2025, some of the successes, and some of the things that we've been able to accomplish, and then lay kind of the platform for 2026, knowing that 2026 is going to be a very busy year and that the PDAB landscape is beginning to shift a little bit. And so to prepare us for some of those shifts, we've really excited to have this expert panel with us this morning. Kelsey, if you could go to the next slide. So we have Rainier Simmons with us from CAN, and Rainier is the state policy consultant for the Community Access National Network. And so welcome, Rainier. We have Derek Flowers, who's the Executive Director of Value of Care Coalition and is a terrific state advocacy partner. And we are very excited to have him with us as well. And then, of course, we have Bridget Serrett, or Bridget Dandra Serrett. I'm sorry, Bridget, I always kind of forget the dash, and I apologize. She is the founder of Advocates for Compassionate Therapy Now, and Bridget's also a member of our RAP Patient Engagement Caucus and a leader on many of our access issues that we take on at RAP. So welcome, Bridget.
Thank you very much. And I answered to anything. So,
Well, welcome. Welcome to all three of you. We do have a discussion guide that's up for people who are participating in the workshop. We will start by looking back at 2025 and start considering some of the, not only the actions, but what are some of the key learnings and themes that we've seen in 2025? What are some of the areas of success? And then how can we move that forward into 2026 to address some of the changes that will occur, to become better prepared to advocate and to take our messages, whether it's to state legislators, whether it's to governor's offices, other advocates, so how can we better be prepared for 2026? Then we will also then open up at the end for questions and answers, but we'll also talk about a specific advocacy opportunity coming up in January that we want to get on your radar screens and make sure that if you're able to participate or have someone who can participate, that we get that on the schedules right away so that we can have a very successful event in Richmond, Virginia in the 1st of January or in January. So with that, Kelsey, if we could just go to the next slide very quickly. So just by way of overview, I did put together a quick slide to look at the PDAB states that will be part of our discussion, and so that we can have kind of a reference point on the screen. So as we're talking about things, there will be a little bit of visual background. Kelsey, could you go to the next slide? So what I'd like to do is turn some time over to our panel to talk about 2025. What are some of the, challenges that we faced, some of the opportunities, and some of the key themes and learnings. And I'll kick it off by just taking a quick dive into Virginia. We were all very active in Virginia this year. We had a piece of legislation moving, and we had a lot of support for the bill amongst the proponents of the bill. Of course, it passed both the House of Delegates and the Senate, and then it was vetoed by the governor. And a number of us participated in both the advocacy, the actual day-to-day lobbying, op-ed pieces. I know at RAP we did some educational campaign, paid media, and we also did support letters, support for the veto, support for alternatives, and other things like that. So I'd like to turn it over to the panel to talk a little bit about some of that activity and some of the things that you took away from that that could be utilized in other states. Derek, go ahead and jump in.
Yeah, I'll jump in on Virginia. You know, like you said, Mike, it's a place where there was a lot of support for the PDAB, but also a lot of opposition. And the sort of tactics that you laid out were all important in their own right, I think. You know, part of the struggle with or the challenge I'll say in advocating around prescription drug affordability boards is the first step, which is raising awareness, right? Those of us on this call may be well aware of PDABs and the challenges they present, but the general public may not be, and policymakers who are charged with making decisions about whether or not to create a board like this also may not know exactly what some of these unintended consequences that concern us might really entail. Let me take a step back quickly. You know, PDAB, as Mike mentioned, is Prescription Drug Affordability Board, a government body that's authorized by the legislature with members appointed by public officials. They're charged with uh, reviewing the cost of certain drugs. And if they deem them to cause affordability challenges, then they may be authorized to institute what's known as the UPL or upper payment limit. And this is where a lot of us have concern. And so in Virginia, I think that all of the above approach really, really paid off these last couple of years. And I think you saw evidence of that in the veto message that Governor Youngkin issued when he talked about some of the things that we've all talked about with regard to concerns of access. And so, I think that the takeaway from the work in Virginia last year was simply that a variety of voices, a variety of perspectives, um, really matters. And if you can get policymakers to listen, then you can really make an impact too.
Absolutely. I would have to add too that, going forward, there are several states that have had this type of legislation rolling for some time.
Mhm.
And I think people are starting to realize that the upper payment limit is not something that's going to help save patients money. It's more along the lines of an insurance reimbursement cap. So it's going to cap what my insurance can reimburse my pharmacy or my infusion center. And so I think the reality that these programs aren't saving any money and they're costing lots of money and could impact access to critical drugs is starting to become more clear.
And yet, Rainier, I'll turn this question to you. As we've seen in Virginia, and I think there is a little bit of PDAB exhaustion legislatively over the last 4 years in Virginia. But just across the river, the Potomac in Maryland, we did see some traction gained by those who are supporting PDAB in terms of, giving the Maryland PDAB UPL authority. Um, and so it is as Derek and Bridget indicated, it is something that we're making some headway on, but still there are these misperceptions about what a UPL can and can't do and the impact of a UPL. Rainier, I know that you were all very organized and really advocated a lot in Annapolis. What did you see was the difference across the river, and what can we learn from some of the activities that occurred then in Maryland?
Well, I think in even in Maryland and just all the state boards that are active across the country, that this past year it's become clear that they are increasingly understanding that trying to institute UPL is a problem because even in some of the deliberations, whether it's patient advocates bringing it up or actual patients bringing it up, or even some of the board members having questions, it's clear that even though a lot of them are still pushing forward, trying to do UPL things of that nature, it's clear that they are obviously questioning the efficacy of a UPL. And even though they still have there are several actors in the background who keep on trying to push it, I think the increased pressure is causing more of a highlight on the fact that UPLs don't work. And that's going to be something really important to kind of continue to educate and kind of push and keep in the limelight, um, to show them that it's important to look at other options, especially in boards like Oregon, for example. They literally had changed their whole kind of like paradigm, and decided to look at more options that are non-UPL based. And that was, vastly different from the way they started out, to the point where their most recent meeting, where they actually voted on several different measures to give to legislature, they specifically decided not to recommend UPLs. Now, granted, it wasn't unanimous vote, but it still did not pass, so they are not recommending it. So they're kind of going along with their, kind of like a new focus on options that can actually work for people. I just think it's really important that, I mean, even in states like Maryland, where there are voices that are educating people about UPLs, but then you still have a very strong subset of energy that is trying to push it. And that's where I even saw some frustration on the recent advisory council meeting they had, where even on the advisory council board, there were some members who were clearly understanding that UPL is not the best thing, but then you had a couple of members who were really pushing it. So I think it's just really important to continue to raise the issue and the education about the fact that UPLs are not a good solution.
Yeah.
So let's talk about UPL for a moment and one of the shifts that we saw this year a little bit. So a UPL, as you all have described it, is a payment limit that a plan can pay for up to that point, and then either the drug's not available or someone has to pay for the difference in order to access the medicine. And as we've talked about at RAP, and I know having discussions with each of you, often the person who's going to have to pay for that is the patient if they're going to retain access, if they can even continue to get access through their plan. Um, but there was a subtle shift this year, I think, as all of you characterized this pushback on a UPL and kind of a recognition that, it doesn't quite it doesn't do what it's intended to do, which is lower patient cost. But there is a shift to move down a road towards surrogates for a UPL. And so we saw that begin to creep in this year, beginning with Colorado, certainly with Maryland. And other states are talking about use of this surrogate, which is called a MFP, or a maximum fair price. Um, could you take on maximum fair price and help us understand how that would be utilized and why it might be utilized as a surrogate for a UPL? And again, how does it impact the patient?
Mhm.
Yeah.
So, you want to,
You can go ahead, Rainier.
oh,
That's
okay.
great. Yeah.
So maximum fair price, coming from the IRA, is basically trying to use these boards are trying to use maximum fair price as li- uh, uh, a amount to set their UPLs at. And the issue with that is, one, by doing so, you ignore the needs of your actual state and whatever affordability needs are actually in your actual communities. Because by using that, you haven't looked into what your community needs, and it's a potential that if you use that as a cost cap, you could cause all sort of like adverse effects. And additionally, it's an issue because, well, one, it's not even really fleshed out in the government yet, because it has yet to be enacted. It will start this year, so we don't even know what the outcomes are going to be. And then additionally, the way it's set up for the government, so since for people who don't understand how it works, so since it's a sort of a price cap for Medicare, um, it actually has a kind of a two-part system where whatever the price cap is that pharmacies and so forth have to purchase these drugs at, the manufacturers are then responsible to come back and pay them difference if it's less than what they paid to get the drugs. So if a state decides to, for example, say use the MFP for UPL, that's a problem, because if that MFP amount is much lower than what it costs people like pharmacists to actually acquire the medications, then they have to get at a loss, and the state has no um, sort of like safety net to help them make up the difference. So not only are you affecting, what your constituents may actually need, you're also harming your pharmacists, which also harms access, because the pharmacies can't operate, then they can't get their drugs to their patients.
Yeah, just to expand on that a little bit, MFP hasn't even taken effect yet, right? It will be in effect at the beginning of next year. And seeing states race to use it as a convenient benchmark for pricing for their consumers is a little bit frightening when we don't know the actual outcomes of the MFP pricing yet. But if you look at 2025 data, you can start to see some real trends. Rainier was talking about the challenges to pharmacy. There was a series of surveys conducted by the National Association of Community Pharmacies. The latest was in September, and I think the stat was about a fifth at the time, a fifth of independent pharmacies had decided not to stock at least one of the MFP subjected drugs, and about two-thirds or 67% were still considering whether or not to stock them. And that's because of the reimbursement challenges that Rainier laid out. So there are some numbers around that, but imagine if, 1 in 5 pharmacies don't have the treatment you need, clearly there's an access barrier. And then you talk about price. So there were a couple studies this year that showed that looked at Medicare Part D plans and showed that I think of the MFP drugs, the drugs that would get the first MFP rates in 2026, the plans were already adjusting for that to take place. So for those drugs this year, there was an average out-of-pocket expense increase for patients of 32% across those drugs. And there was a marked shift amongst plans from copays to co-insurance, meaning more plans were shifting costs, to patients in addition to, I mean, part of that was probably what's driving that higher out-of-pocket cost, of course. And early looks at 2026 plans just show that trend continuing. And so the idea that MFP is going to save money for patients may be a bit flawed. That remains to be seen. Evidence suggests that maybe that's not the case. And then add on this question, right? So we've seen MFP applied as the reference price to a drug in Colorado. It's being recommended for at least two in Maryland right now. But there's been no talk of exactly how to set a price when that convenient benchmark doesn't occur either. And so the flip side of using MFP as a reference price is how will they determine the right price when the federal government hasn't already, done that work for them? Remains to be seen in 2026.
Absolutely. Here in Colorado, we're not as populous as a lot of the coastal states. Our entire state has less people in it than most metropolitan areas on the East Coast. And so we have a lot of rural hospitals, rural patients, and a lot of geographical challenges. So if local pharmacies cannot carry these medications, it really puts the patient at risk for higher medical costs, more surgeries, things like that. And you also will see where our particular board, they set our UPL for Enbrel at 600 just because they had a need for even numbers, and it was over the MFP. So there is still no consistent way or formulary to come up with a UPL. So it's like they're just pulling things out of their hat and trying to just figure something out. And so when Cosentix comes up that doesn't have an MFP, it's going to be interesting to see how they do that.
I think, Bridget, you kind of point to something here that Derek had mentioned earlier, is that there's almost this train rush to get out of the station and start setting prices, and MFP seems to be the easiest, quickest tool to peg onto, regardless of the implications, how it will impact pharmacy, how it will impact, physicians and, practices that maybe infuse products. And so that use of MFP as a surrogate, when we really don't know that much about MFP yet and how the market will adjust to it or be able to, continue to provide access, is really kind of putting the cart in front of the horse. But I think, and in 2025, we've seen a lot of political pressure on these programs to actually do something, right? Whether it's Colorado, whether it's Maryland, there has been some intense political pressure. And we were all participating in this last June when Maryland got their UPL authority, and then now here we are later in the year, and they're rushing towards MFP. So I think part of this is that they're under intense political pressure to accomplish something, because we are seeing that UPLs don't work.
Hmm. Well, and I think we've also seen in 2025 what could happen to a PDAB if they don't accomplish something, right? Look at the case of New Hampshire, for example. This is a state that had a prescription drug affordability board. It had not saved anybody a single, penny on their prescription drugs, not a patient, not the state. And presumably it was costing money, like we've talked about, for them to operate. And this year you saw the legislature defund and disband that PDAB. I presume in recognition that there may be better ways to make sure patients have access and reduce patient costs at the counter. And so I think you're Mike, right? Like, or you're right, Mike. Like in the face of that, probably some PDABs do feel pressure to take some action.
I would add to in the fact that some of them are take feels like so much pressure to move. The issue with that is they're trying to move and they kind of have the mindset of, well, we have to do something. So let's just do something, and then if something bad happens, we'll deal with it. And that's not a good thing to, not a good mindset to have, because when something quote unquote bad happens, that means patients have been adversely affected. And when a patient adversely affected, that's immediate. And a solution to whatever that bad effect is not immediate. So the problem I've seen in several states, especially like Maryland, is that they have these ideas and wishes to move forward, but they also do not have in place any safeguards or any ideas of how to protect patients. I mean, Maryland specifically, they acknowledge the fact that, for example, it will take legislative action to make sure that drugs that have UPL set have to stay on the formulary, but they haven't really talked about that. So they're trying to move forward with no patient protections and just have the idea, well, we'll just see what happens, and that's not a good thing.
Rainier, I think that's an important point, is that we've heard that from a lot of PDAP proponents. I recall a couple of conversations I've had with some legislators here in Virginia over the summer. And, when we pressed them on how the PDAP would work, how a UPL would be implemented, and, the potential impact on patients, they literally looked at us and said, well, we don't understand quite how it works, but we have to pass the bill, before that, and we'll come back and address those issues as they come up. And so there was that sense of look, we're doing this. It's on the train rails. It's moving. You got to get on board, or we're going to leave you behind. But we don't know where we're going. And I think part of the MFP discussion that we just had is a way to take responsibility off of that board and say, oh, well, we just used something that CMS came up with. And we're going to save everybody money. Again, not understanding the implications. It's kind of like doubling down on the unknown, with both a UPL and then you know taking on an MFP as a surrogate for a UPL. We're doubling down on the unknown.
Mhm.
And if patients lose access, we're going to have to then come back and fight to fix it, because that's literally how it would be set up with some of the legislation. There's really not a method in the implementing legislation to fix it at that point. And so you have to come back and run a technical amendment, then you have to run all the traps, et cetera, before you can come back. And patients have lost access by then.
Yeah, you're right, and it's something that they don't seem to want to fix in advance. You've talked about Maryland. It's in 2025 been a dual threat state, right? The PDAB exists. It's going through cost reviews and now looking at upper payment limits. But as you referenced, there was a legislative threat this session too, which expanded the PDAB's reach. Previously, its scope was limited to state and local government health plans. With the passage of legislation this spring now, it can impact all commercial plans in Maryland. As that was going on, advocates, I think probably everyone on this call, certainly others too, proposed an amendment that would suggest the PDAB should be required after it's set a UPL, if it chooses to do so, to wait 2 years and then do a look back and see if all of the things that we're concerned about had come true, if some of them had, if none of them had, if patients were benefiting, if providers were benefiting, if pharmacies were being hurt, what really happened before expanding that scope to impact all Marylanders through the commercial market. And that amendment wasn't taken up. The sense we got from some legislators was, well, we don't want to see any delays in this. And so let's just get moving and let the PDAB do its work. And so now here we are, and Rainier's right. It's easy to say, well, we'll monitor it. We'll see what the outcomes are, and if there's any unintended consequences, then we'll address them. But nobody talks about exactly how that will happen or how fast and what it means for the patient who actually experiences a loss of access to the medicine and can't have their treatment. These drugs that all of these states are looking at are innovative, life-changing or life-saving medications, and to not have access could be devastating for individual patients.
And just a quick comment, and then I'd like to kind of continue the 25 wrap up, Bridget, in a second. One of our attendees has noted that since Oregon only meets every other year, this would cause potentially 4 years of access issues to try to navigate a fix.
And honestly, that's if they can get it passed through the legislature. I can tell you, Colorado has zero safety net for the patient. We've brought this up multiple times, and the boards has taken the stance that it's not their problem. If we want protections, it's our job to go to the legislature. Um, they're not going to help, and we have not had good success getting legislators to take on this legislation. We have a very strong governor who has put a lot of pressure on the PDAB and a lot of pressure on the legislature to make sure that something happens, with a UPL and they make air quote progress. But unfortunately, patients are caught in the crosshairs of that, and we have no recourse if we lose the medication that we need.
So that's an important learning from even our past couple of years, right? Is that, the implementing legislation often doesn't have the protections, as Derek said. There's no look back provision to assess the success or failure of a UPL. The appeals are often fairly limited. And again, as we've discussed as a group before, often patients are not represented in the intricate workings of a PDAB. They're often an afterthought that's kind of tacked on at the end, versus being a voting member, looking at these products, and then providing substantive feedback and maybe even getting a vote on what a shape oversight would look like from a PDAB. So, it's as we've looked at Colorado, and Bridget, you can speak to some of the dysfunction that we've seen there this year. There's not a lot of patient voice. There's not a lot of physician voice as the voting members on the PDAB. And in the case of Colorado, not a lot of in-state voices.
Yeah, absolutely. Our board, two of the members live out of state, and there are very few opportunities for providers to put input in, and very few opportunities for patients. The way they have done it in the past has been very quick, posting a survey on an obscure website, and when they don't get the response to that obscure website because we don't magically know this is happening, they just continue forward. The other issue we have is our entire board is nominated and appointed by one person. So there is no diversity of thought at all. So the governor appoints every single board member, which means that he's making sure every single board member only does this and will only do what he says. And so you don't have the robust discussion, you don't have the diversity of thought, you don't have well, maybe a UPL won't work, but maybe something like PBM reform would work. So it's been a challenge for sure.
And Bridget, that's an interesting point. And I think we can cap off our 25 discussion on that. The makeup of the PDAB themselves are political appointments. And the way that they're constructed, there's often nobody on that PDAB. Now, you might get them on the advisory board, the PDAC, that has maybe a little bit of trade experience, a little bit of pharmaceutical experience, maybe some physician experience. But as we've seen, those political appointees will often override or ignore the recommendations of their advisory committees that are set up kind of sub the greater PDAB. And so I think that's an important point is the political nature of filling out these PDAB boards is that there's not diversity of thought, there's not expertise there in terms of how reimbursement works, how physicians are paid, how pharmacies are paid, what's the impact on the patient journey. We see that in some of the blank stares that come back to us during PDAB board meetings. It's like we're talking a completely different language because, we have people on these PDABs who are regulating an entire sector of their economy and an entire kind of avenue of access for patients and have no clue uh, what that means or how it works.
Yeah, I can say with Colorado specifically, it took a long time for the PDAB to actually show they had some understanding of what they were doing. They cited, saving uninsured patients money or Medicare patients money, and these UPLs do not impact Medicare. They also didn't really understand how the patient experience works with patient assistance programs and things like that. And they did not translate their data consistently. They weighted some heavier than others. And then for the next drug they reviewed, they were like, oh, well, we can't weight it that way anymore. I think they were getting pressure from above to actually do something. And so they changed how they interpreted the data, even though it was relatively the same. So it's been difficult.
Well, with that, I'd like to jump into 2026. And Kelsey, could you go to the next slide? Uh, Jump one more so that we can, there we go. Perfect. Thank you. Because I want to kick this off with a question that did come in because it's relevant here as we shift into 2026. We had someone who asked the question is, well, if Virginia is moving forward with legislation, how have they been able to move forward without choosing to study it more? And this is an important question. And of course, we brought this up in our follow-up with Delegate Delaney, this very topic, and recommended to her that it go to study committee in Virginia, and so that they could actually study how it would work, how it will impact patients, get feedback from pharmacists and hospitals and physicians and patients, and then come back to the legislature with a recommendation. But and yet it happens more than just in Virginia, right? That these bills move forward without that kind of analysis. And so as we talk about 2026 and moving forward in Virginia, that's an important point. And I want just to ask all of you how we can kind of move that point forward, that this is something worthy of taking time and discussing, particularly as we've seen dysfunction in Colorado, we've seen a repeal in New Hampshire, and now we have supporters pushing on the gas and saying, no, but you must pass it in Virginia.
Mike, I think we're at a really important moment in time for that idea, right? I mean, previously, if you look to this past year, the year before, people might have said, well, what are we going to study? It's theoretical. We got to do something. We can't wait for the feds. They're so slow. Other states are doing it. Let's go too. But now, as we approach the 2026 legislative session, there are a lot of things happening that might be worth actually studying, right? As I mentioned before, the MFP will take effect in January. Let's see what happens there for those 10 drugs. Let's see if access is impacted and what happens to patient costs in the Medicare program. At the same time, Colorado has set its UPL For Enbrel, Maryland is poised to do so on two drugs. Um, let's see what happens there now that two states are doing that. Let's let it play out. Let's look and see how access and cost are impacted. And whereas it might have been um, difficult to make the case to do that before because it seems so far away, or there was no one knew when these things might take effect. I mean, MFP, yes, but the other states' activity, no. Now we know those things. And so a legislator might be wise to say, especially when they all want to look at what other states are doing, they might be wise to say, let's see what Colorado did and what the outcomes were. Let's see what Maryland's doing and what the outcomes are. And really consider that before they take action in their states.
I'd also add to you bringing up the question, Mike, is that unfortunately, a lot of these boards, even when you ask them to do studies or analyze how things will affect their actual state and constituency and their economy and so forth, they have I don't even know if it's a pushback is the right word, but basically they just don't want to do it. And that's a problem because I think they don't want to do it because I think they feel if they do, then it'll show that what they want to do with UPL or other things really won't work. And I think that's something as far as going to 2026 is important to keep kind of like keeping a limelight on is to address them and make them kind of continuously ask them the question, how will this affect your state, your people, your economy, your budget? You haven't looked at it. You need to look at how things are going to happen before you try to do things. Because they don't want to look at it at all.
Absolutely. I think Colorado, they say that they're going to monitor it, but I don't know that there's an actual plan in place. So what does that look like? What does that mean? How are they going to be able to tell? Because most patients, when it's denied, they're not going to say, oh, it's because of the UPL. They don't understand what's happening, the intricacies of the supply chain, or how the upper payment limit is going to affect things like formulary changes or out of pocket costs and things like that. So they may not even know to report it and say, hey, this is what's happening. So it's just a big question mark here.
Yeah. The other thing I might chime in with, Mike, is in the last section we talked about the difficulty in getting patient voices or clinician voices engaged in the PDAB world, right? Where they're operational. They often don't do a lot to make the meetings accessible. If you happen to be available in the middle of the day and can show up and testify in Maryland, you get 90 seconds. In Colorado, it's what, 2 minutes, maybe three, depending on the type of hearing. So not a lot of opportunity and not a lot of opportunity for dialogue. Honestly, a lot of times you just kind of talk and maybe they listen, maybe they don't. Legislatures are a different story, I think. Part of our mission in getting started on this was to stop bad policy from spreading, and that means, look at states that are considering legislation to authorize a PDAB or somehow, institute reference pricing on certain drugs. And in those places, like Virginia, like you're talking about, where legislation is under consideration, I do think individuals have a much greater opportunity to be heard, going to visit to a lawmaker and dialogue with them about the pros and cons of an issue or the unintended consequences that we fear because we're hearing it from important supply chain actors like insurers, pharmacies, and others. It presents a good opportunity for engagement. And if I could leave, the people on this call with one idea, it's that legislatures offer a big opportunity, I think, for us.
I think you're right, Derek. And I would also have those on our workshop and those that they interact with also consider it's not just the lobby days.
Hmm.
It is showing up, getting into offices when you know it's in the committee. It's taking time to call a legislator, to show up and speak with them face to face. And a lot of times those opportunities are outside of lobby days. You know, days are great because everybody descends, we go and disseminate information, etc. But what happens after? When the nuts and bolts discussions are occurring, are there still patients there? Are they still in the room? Are they saying, well, no, that doesn't work? And so it's really important when you're working inside your organization to make sure you're there and that as you all have pointed out, it's hard for a rare disease patient to get there and be there full time to really help create the right policy. And yet that's almost what it does take. So we have to engage maybe a little bit more creatively, whether it's through Zoom calls, whether it's relying on a colleague who says, okay, I can get there this day if you can cover that day. And then being able to hand off and make sure that there's always someone there. It's labor intensive. But we can't just rely on those booked lobby days and expect that we're going to get good legislation out the other end, because legislators expect that. But if you're there as part of the dialogue, which proponents of this bill, honestly, they have deep pockets and they end up there, then you're going to get some things in. So, can you show up maybe at a community event? Can you show up at a barbecue or something where a legislator's going to be at? Can you maybe break off and take an afternoon and get to Richmond? And start looking at it that way, that that once a session or twice a session lobby day is not necessarily going to be sufficient, and it does take a community to cover that type of depth of interaction to make sure that they don't push something through and your voice isn't heard. um, the other side has lobbyists. They have advocates who are paid to be there, and often on our side we don't. And so that's something moving into 2026 that we need to be aware of, and really, as we our focal point is on some key states, how can we develop that coverage together as a community to make sure that, hey, there's a hearing coming up, but we need to be in people's offices prior to the hearing. We need to be in there after the hearing and say, oh, you heard some things. Well, by the way, most of those other people supporting it were talking about Medicare coverage. This bill doesn't cover that. And we need to have a conversation about people not on Medicare. Those types of things need to be done. And I know it sounds daunting, but it's something I think we need to consider moving forward for us to be effective.
Absolutely. Something else to consider is, especially during election years, a lot of these legislators will have town halls where you can go, you can sign up, you can talk to them, or it's via Zoom. I know in Colorado, a lot of our state legislators are very responsive. I've been setting up Zoom meetings for community members to talk about the impacts to them, to policy. And one thing that I have found very effective, as a patient, I have got some pretty heinous X-rays. There's a joke, in my community that the entire legislature has seen my nudes because I've sent them all my X-rays. But that I've even gotten text messages back from legislators going, "Oh my goodness, can I present this? This is insane." And it talks about what happens, when you lose coverage, and the destructive nature of a lot of these diseases, and how these medications can help prevent that and keep us working and keep us in the community. Um, so it's so important to actually build relationships with not just your legislator, but with the as many legislators as you can.
That is very good advice, Bridget. And you know, again, from my experience, I've gotten on now email lists from legislators. I know when their events are. I show up and talk to them. Of course, there are, being an election year or leading into an election year, there are fundraisers, and unfortunately, those are pay to play. And so I'm very selective because it can get expensive. But again, it's how do we get in front of them in kind of a non-traditional sense so that we can counter those professional lobbyists and advocates who are in there, spreading their misinformation about PDAB. And so that's really important. So let's look at Virginia kind of moving into 2026. I know at RAP and with all of you, because all of you have been involved with us, we have some big things going on. We just sent in a sign-on letter, And thank you to all the organizations who signed on to raise this as a legislative priority that we need to push back on PDAB. We are doing legislative alerts to Virginia right now, which will pull up aspects, and many of them you covered on our conversation on why PDAB doesn't work, why a UPL is the wrong mechanism to lower patient out-of-pocket costs. We're pointing to material and things that were generated not just by RAP, but by your organizations. So we're sharing, for example, the plans and how they don't intend to cover these products if they end up with a UPL. We're sharing information from patients on what affordability means to them from each pick. We're sharing information to the legislators in these little bite-sized legislative alerts that will keep going to them before the session starts. And then we're going to kick it off with a breakfast at the beginning of the session to get our advocates there in front of them. So there's a lot of work going on in Virginia to see if we can, stop the bill and then push it to study committee, as we've talked about. Um, I'd like to have each of you give your thoughts not only on Virginia, but we've talked about Maryland, which was just given UPL authority more broadly. We've talked about their use of MFP. We haven't talked about MFN yet, but we know that states are talking about MFN
Yeah.
because guess what? The federal government is talking about it. And so, you know, um, as we look at the next steps in these states, what are the key aspects for getting involved, linking with organizations such as RAP or Value of Care Coalition or ACT or CAN? And so I'll stop there because I have so many other questions as well.
There's a couple questions there. I'll hop in quick on the first part. MFN you referenced, typically means most favored nation. Another way of putting it is international reference pricing. And so typically, a government body will define a set of countries and look at the drug prices in those countries and try to apply that to drug prices in our country or in a certain state. In Maryland, that's one of the frameworks that the PDAB can use to determine where it wants to set its UPL. They have laid out many different sort of reference prices that they will look at and I guess in theory determine which fits best for each drug or maybe what combination or what average might work best. As I mentioned before, for their first two drugs, they chose MFP, but they just as easily could have chosen some type of international reference price because that's allowed in their processes. Other
And
states in 2026 will certainly look at legislation that cuts out the PDAB entirely, um, and and sets a type of reference pricing within the state. We've seen states look at automatic MFP reference pricing, meaning that if the Medicare program sets its price for certain drugs, then that price would automatically be the upper payment limit in a state. This year, I think we'll see more of that, and we'll also see legislation, I think, based on what's happening at the federal level that would look at a basket of other countries and try to sort of import their prices at that state's level as well, which we think is equally concerning when it comes to cost and access.
I think, Derek, as you look at MFN, and rare disease, it's
Yeah.
important to understand that a significant proportion of rare disease therapies never launch in these other countries.
Absolutely.
There's a reason for it in terms of the ability to access small numbers of patients and the ability to make it available, that the economics often do not line up. So when you put together an MFN market basket, you're going to have significant gaps, particularly in the rare disease side, where these products and across chronic care, to be truthful, but a little bit higher proportion of rare disease products do not launch in these countries. And so, for patients, it's something that, again, is a distraction from how do I lower patient out-of-pocket costs? How do I improve access to affordable insurance and manageable out-of-pocket copays?
Mhm.
um, because MFN's really going to be again a scatter shot when it comes to rare diseases. Derek,
Yep.
I'm sorry, Rainier, did you have something as well that you wanted to add?
Oh, well, I was not admit I was agreeing with you. But it's specifically when you talk about things like MFN and rare disease, especially the issue is that outside of other countries, the manner in which they economically decide, what drugs to purchase and pricing and what to use for people and what they value as effective means of treatment is much different than the way we look at things in the United States. So if you're gonna, people are trying to use like something like MFN, you're already automatically discounting, especially people who are rare diseases and chronic diseases and things of that nature.
And just to flag for folks on this call, it's not theoretical. We've seen one of these bills introduced already for 2026. Florida has an international reference pricing bill that's likely to be considered when they gavel in January, and I wouldn't be surprised if we saw more.
Absolutely, absolutely. Just to give an example, with Trikafta, if you were to import the price controls on Trikafta, people, they're like, oh, that sounds like a great idea, without realizing that a lot of countries still do not have access to Trikafta, and that is a life-saving drug. That is pretty much almost a cure as long as you take it for cystic fibrosis for that particular genetic mutation. Yes, they still have cystic fibrosis, but this drug has been life changing. And I know people who have watched friends in other countries die waiting on access to that while they work on price controls.
Yep. And
So, as we look at the states, we've obviously got some live legislative states. Derek, you did add a state that we've been monitoring in terms of international reference pricing and the debate there. And again, sidestepping a PDAB now and going for something that would kind of just avoid a lot of the difficult discussions that we've kind of gone through this morning. We've got Maryland and Colorado and Oregon, Washington State that are in kind of the regulatory side. They're in the rulemaking side, right? What's important looking forward? I know a lot of them publish their agendas, their calendars, etc. How can we make those interactions more meaningful in 26 than they were in 25? What are some things that you would recommend to our participants in the workshop today?
Well, I'd recommend something you mentioned in your last question, which is if you're not already, get in touch with one of our groups. I think everybody, here, every panelist and the organizations they represent tries to do the best job they can of letting people know when opportunities exist. And so that's the first step. Know when something's going to happen and where sort of the best bang for your advocacy buck or amount of time spent might make the most impact. Secondly, I maybe this is actually step one. I'd encourage more people to get engaged. You're right, Mike. We do typically know ahead of time when those meetings are set to occur. They're not always great about releasing the materials or the agendas ahead of the meeting, so you have to stay on top of that. But in a lot of the states where PDABs exist, we know the path they're on at this point, what drugs they're looking at, maybe what month or months they might be considering them. So plan to engage, and I think that the more they hear pushback from people, the more it resonates. Right now, like we talked about, they don't hear from a lot of individual patients or a lot of individual clinicians, and so I think it's important that they do so. And if they do, and they hear that there are concerns, it might make a difference.
I want to share a comment that we got and really just endorse this comment because this is something that can be useful in other states as well. As many of you know, we do have an effort going on here in Virginia, and it's with the Fair Health Virginia Coalition that is working with actually the proponent of PDAB, Delegate Delaney, to move a bill that would basically require a copay only health insurance option in Virginia. Again, plans aren't required to offer that option in Virginia, and in fact, the choices that Virginians have are often on the coinsurance side, and they're expensive. And especially when you start looking at rare diseases, the percentage out-of-pocket costs can really, really, reduce the ability for families to access expensive therapies. And so Lauren Edwards had sent some information into the chat. She leads the Fair Health Virginia Coalition, and she has been a terrific partner here in Virginia, not only to understand how it would work here in Virginia, but the template for other states that this legislation could go to. Their organization is happy to share their fact sheet. Lauren, we will also provide the links to this after the meeting to attendees and get that out. And they're happy to encourage folks here in Virginia, again, to speak to your legislator about alternatives that can save patients out-of-pocket costs almost immediately. Okay, so whereas PDAB's theoretical, and we've seen it save no patient or anyone money in 9 years almost. But we do know that there are things that can save patients money out the gate, and this is one of them. And so, Lauren, thank you for the comment, and we will provide links to that after this session. Um, so, again, some additional thoughts. I know we're going to be running out of time. Um, any additional thoughts before I'm going to move to a slide to share the Advocacy Day here in Virginia.
I just like to add that, especially going into 2026, is as we've seen in places like New Hampshire, I feel like the more that legislators understand and see how PDABs operate, the more they don't like them. So it's going to be important to continue to raise awareness, and that requires us to, get in touch with legislators so they will understand instead of having to wait for, a PDAB to send them a report or someone to decide to give them like, some sort of information. It's going to be important to really stay on them and educate them as to how they do not work. And the more that they understand that, hopefully that will, help them to understand it should not be instituted. And so what you were saying, um, earlier also about just lost my train of thought that quickly. Um, well, I'll leave it at that.
I would just want to encourage people to not be intimidated by talking to your legislator. And if you are, reach out to your local organizations because we will help you and help guide you. These folks work for you and they're everyday people just like you. They put their pants on one leg at a time, hopefully. So, you know, they work for you. Your voice matters and it's important that you get engaged.
And just to kind of put an exclamation point behind that, Bridget, Lauren, thank you for your comment as well. She noted that there are 137 drugs on the preliminary Oregon list for 2026. Now, we've seen some progress there with Oregon willing to look at things that they can do in the PBM space, in the access space, to affect benefit design and make access to therapies and care more affordable without a UPL. But it's important to remind ourselves that there's still a list of identified products that potentially could move forward in 2026. So we can't not be vigilant on these states, even though they don't have active legislation, where we need to actually be involved and to share, again, information, patient experience, how it impacts you, whether your drug's on that list or not. And so, again, thank you for the comments. I'm going to turn it over to each of you for just a quick closing thought, and then we will pop up our Virginia Lobby Day information. Derek?
Sure. Thanks, Mike. My closing thought is this. We talked about a lot of bad news in PDAB land, but there were some positives that came out of 2025 too. I think in Oregon, we see a PDAB making recommendations to the legislature for policies that are not related to upper payment limits, things like PBM transparency and other things. In Maryland, they're of course setting UPLs, but they're also looking at non-UPL policy options. They're not giving it the priority that we'd prefer. We'd like to see a little more action. We hope it's not lip service, but at least they acknowledge that UPLs may not be the be all end all of fixing healthcare costs and affordability issues. And then, look, over the last two legislative sessions, as a community, I think we've done a great job in stopping bad policy from spreading. And hopefully we can do that again in 2026.
Um,
Derek?
I'd
All right,
just
I'm
like
sorry.
to, oh, go ahead, Rainier.
Okay. I would just like to say that to piggyback on what Derek says, we have had some good news. I feel like going to 2026 is going to be really important to however we're able to do it to get more patient voices on these, talking to these board and legislators, especially the ones that don't always want to trust patient advocacy organizations. So it's going to be really important for us to try to get more patient voices constantly talking to them and engage them, even though some of the boards don't give them much opportunity for engagement, just trying to get more patient voices to utilize what's there. Especially in places like it's not on our list, but places like Minnesota, who basically doesn't have any really input from patients. This is really, really important to get patients to get their voices heard. So legislators and boards can understand what they actually need.
Absolutely. I just want to echo that because your voice matters. Only you can tell your story, and you are the expert because you have the lived experience. So don't fall victim to that imposter syndrome. Get involved, and there are definitely organizations that can help you.
Thank you, Bridget. And thank you, Rainier and Derek. Kelsey, could you go to the next slide very quickly? So, to that, in that spirit, Bridget, um, we are going to be hosting an advocacy day in Richmond. Now, this is in addition to us being there in Richmond on a regular basis throughout the accelerated legislative session this year. So you're going to have RAP people on the ground throughout the session, but this is specific to welcome. It's basically a welcome back to session event where we are going to highlight patient journey. We are going to give patients opportunities to interact with staff. We're going to have educational materials. And then as soon as breakfast's over, the work begins. So you'll get an opportunity to talk to staff as they come and visit, but then we're going to get you into their offices for a very full day. And if you know us at RAP, it is morning right through night. We will be in offices as quickly and as efficiently as possible. And if we have gaps, we are in offices leaving materials, seeing if we can do pickup meetings, etc. We would love you to join us. This is an opportunity to make our voice heard. Obviously, we've done the legislative alerts where we've got some op-ed pieces coming. We've got an additional policy paper coming looking at MFN and MFP and how that's no surrogate for a PDAB. So we will have additional information, but this is an opportunity to get you in front of legislators and staff and share your patient journey and how you access your therapies and why you're concerned about PDAB. So please reach out to us. Kelsey will be building out the event. This takes a lot of work. So, if you have folks who are interested, please share with them, have them RSVP, but then follow up with them. And if they can't show up, see if someone else in your community can. Because we build out calendars, and if people don't show up, we've got holes. We don't have people to show up and get face to face with meetings. It's really important that as you look at your calendar, you RSVP, and that's plan on being with us in Richmond because it will be a very, very full day. Last year, we had multiple teams going to multiple offices all at the same time. And again, it's just a wonderful day of advocacy. So please share that through your organizations. We would look forward to having you there. And then as we move into 2026, we will be reconvening our PDAB seminars. And I look forward to having these panelists back because we'll be talking about engaging in Maryland. Derek, as you had mentioned, and Bridget, that they're looking at more broadly now, finally. And how do we push them to do more than lip service? How do we engage in Colorado and maybe do some technical amendments, Bridget, and see if we can bring some better information to the decision making? Um, you know, in Oregon, how can we continue to be a voice and presence there? In Florida, again, if MFN becomes a surrogate for some sort of upper payment limit, how can we get in there and educate staff and legislators and really help them understand that we need assistance in other places. So again, this is just to tee up those discussions. I appreciate everybody staying overtime. This has been a wonderful conversation. And if any of you have any questions, please reach out to the RAP staff. We're happy to link you to our panelists. And we also have the contact information for Laura Edwards here in Virginia. If you want to be part of that effort to focus on lowering patient out-of-pocket costs and a bill that will be moving this legislative session, reach out to Lauren. We are excited to be supporting her during our lobby day as well. That will be one of our key points is you can do something that helps patients. So with that, we can adjourn. And thank you to everyone who participated.
Thanks, Mike.
You.
Thank you.